Hello, everyone, and welcome to MIT Sloan Alumni Online. Every month, MIT Sloan Alumni Online brings you the latest breaking news, cutting-edge research, groundbreaking ideas, and school updates from MIT Sloan faculty and alumni. Today, we have Professor Joseph Doyle joining us. Joe Doyle is the Irwin H. Schell Professor of Management and Applied Economics here at MIT Sloan. He studies public economics in the areas of healthcare and child welfare. His healthcare research investigates sources of value and waste to inform policies aimed at improving the quality and cost effectiveness of the US healthcare system. This includes partnering with large healthcare providers and payers to conduct randomized controlled trials of changes in the way healthcare is delivered, with an emphasis on addressing social determinants of health. He is the co-director of the MIT Sloan Initiative for Health Systems Innovation and co-chair of the health sector of the Jameel Poverty Action Lab. Joe, we're glad to have you with us. I will go ahead and turn it over to you.
All right, it's my pleasure to be here. Thanks for hosting. I see that a lot of people joined, so that's exciting. I'm going to try to share my screen here. There we go. Okay, so what I wanted to do today was talk about the latest developments in US healthcare and some of the exciting research that's happening here at Sloan. All right, so just to introduce myself, my name is Joe Doyle. I'm a professor of economics here at MIT Sloan. And like we said, I'm the co-director of the MIT Sloan Initiative for Health Systems Innovation. We have about 30 faculty and researchers here at Sloan who do research on health. About 10 almost exclusively research health. So we have a core group of people, and then we collaborate, of course, with people across the Institute and across the world in studying healthcare. I'm also on the board of JPAL, the Poverty Action Lab, here at MIT. And here's a map of some of the ongoing studies that JPAL is doing. What JPAL has done is sort of revolutionized development economics by putting an emphasis on running randomized controlled trials to estimate what works and what doesn't when trying to alleviate poverty. And about 5 years ago, we opened an office called JPAL North America, and most of the funding that we've received so far and a lot of the emphasis is on healthcare delivery. And that's related to poverty, of course, because we spend a lot of money on say, Medicaid programs, and learning how to improve the efficiency of US healthcare can improve the health of everyone. And one of the topics we'll talk about today is how we might have programs that address poverty issues in order to improve health and what we can learn from those policies. I should say I'm a little less used to this type of format where I will talk for a long time and then we'll have Q&A. So you'll have to put up with me if I'm being a bit like a news anchor for a little while. Usually I interact with an audience a bit more, so we'll see how this goes. So today I'll give you a brief background on the changing US healthcare system, and then talk about ongoing experiments, this JPAL mentality, or also the MIT Sloan Initiative for Health Systems Innovation mentality of bringing rigorous evidence to what sound like good ideas, but we really have to test them in the field to see if they actually work and whether payers or providers will actually adopt them in the future. And I'm really looking forward to the Q&A. I did receive a number of questions that were asked before, and so I'm addressing some of them here, but I'd love to talk about them after my remarks as well. Okay, so US healthcare in transformation. This is a graph that, as an economist, I must include in every presentation that I give, which is the share of GDP that goes to healthcare. So the top line there is over from 1970 to 2017, the United States has increased its spending on healthcare from about 6% of GDP up to about 17% of GDP. That's a lot of money. And that's because we value healthcare. I imagine that's why we have so many people on the call today, and that's because the value we place on improving health is so large that some economists have put it at the gains in health that were accrued over a 30-year period from about 1970 to 2000. We could put a price tag on what we're willing to pay for that at around $80 trillion. So, we're talking big numbers, whether it's 80 or 50 or 60 trillion, doesn't really matter. But the point is we are willing to pay a lot to improve health. And of course, we do pay a lot for health, and you can see it there in the green line. Another feature of this graph that I find interesting is we used to be near at the top of the pack in 1970 in terms of share of GDP, but we were with the pack. And around 1980, you see a divergence where the U.S. starts spending more and more on healthcare. And sometimes we do use more healthcare. We scan more than some countries. We do other things more than some countries. But if you actually look at the most quantity measures, we don't consume that much more healthcare. Our length of stay in the hospital isn't longer than other countries and so on. What is changing is the price. So our prices have been growing. The inflation in price has been growing over time. Part of that could be reflecting quality improvements. So it's a bit hard to say that it's all due to just nominal prices. We might want to quality adjust those price differences, but still, we've been spending more and more on healthcare, largely due to the fact that we pay more per treatment. And some of those treatments have just gotten better. So that's something to keep in mind. But that brings us, well, what I wanted to show you is this cost curve. So a cost curve shows the fraction of GDP, and you see it growing and growing and growing until it hits about 100% of GDP in 2080. Of course, unsustainable growth will not be sustained. We'll figure out a way to what's known as bend the cost curve. And so it's important to think about policies that won't make us go to that 100% in an intelligent way. So there are various ways we could ration healthcare, but what we want to do is get rid of wasteful spending or spending that's not improving health, and we want to spend more on what does improve health. And I'm looking forward to talking more about that as we go on. So one reason why we spend so much in healthcare, why prices are increasing, is what I like to think about our unique system of employer-sponsored health insurance and fourth-party payment is what I call it. So you might have heard of third-party payment. That's where there's a consumer and a producer, and instead of the consumer paying the producer, like normal, there's a third party that pays. It's in the middle. That's called the insurer. So we pay premiums, and then if we go get healthcare, a provider will charge us, but then another party is paying for it. But in fact, in the US, we have more like fourth party payment. And that's because the insurance pays providers, but the employer, for most working adults, their employer is the person paying the insurance. And premium increases that go to the employer are fully shifted to lower wages. There's pretty good evidence that when the premiums go up for employers, that results in lower wage growth. And so what we get is this hidden cost of healthcare. People like their health insurance because they aren't really paying most of the premium, and they like going to the doctor and having a good insurance. But what they probably fail to realize is that as those premiums go up and up and up, their wages are growing, but not as fast as they otherwise would have. And so people complain about wage stagnation. And in fact, some of that is due to the cost of healthcare going up over time. So we don't have the political will to lower spending in healthcare because people don't really pay it themselves, and they're far removed from paying it because not only don't they really pay for the healthcare, they're not really even paying for the insurance directly. They're paying for their insurance through lower wage growth, which is just too many steps removed for voters to get excited about trying to change the way we pay for healthcare. Now, where it does come in, where voters do get engaged, is that state Medicaid systems are gobbling up more and more of budgets of state budgets. And so we're having less to spend on other things like education, roads, infrastructure. And so people do realize that something needs to be done. Medicare, oftentimes we'll hear concerns that Medicare will run out of money soon, and aging population, we're going to have to do something about it. We would probably do that earlier and sooner, and maybe with less disruption if people actually internalize the fact that that getting the latest technology and paying for the latest drugs increases the price that people are paying for healthcare, and that's just leading to us paying more and more over time. This is another component that maybe those new technologies are beneficial, but I think there's a widespread agreement that there's some care is relatively wasteful, some care has a lot of value, and so we would like to strip away the parts that are wasteful. Who's going to do that is a fascinating policy question, because other countries have chosen the government to ration how much they pay for healthcare and how much care will be given. We haven't shown that trust in our institutions in the US to let the government really do that. So in the 90s, health insurers were doing this, and there was a big backlash against that. So what we've been doing in US healthcare is we've been coming up with new payment models where either private insurers or the government are now starting to pay providers based on value that they provide. So you might start hearing about very expensive drugs to treat cancer, for example, and we may start paying only if they work, only if they improve someone's life will there be a payout. So the providers who are purchasing those drugs and using them will take on some risk now about whether what they're spending on is actually valuable. And so the person that's making the decision of whether to spend the money, the provider in that case, will take on some of the risk. It's problematic when the people paying for things are not taking on the risk because they don't internalize the fact that costs are going to be unsustainably growing. So these new payment models are putting more risk on the part of providers. Providers aren't entirely comfortable with this, but some are leading the charge, especially here in Massachusetts. We have a lot of leading what are called accountable care organizations that will take funding and take on risk for how well their patients are over time. So with these new payment models and an explosion of data, this gets economists and econometricians extremely excited. And that's because there will be these new delivery models that are being developed. Not only econometricians and economists, but our engineers here at Sloan and our organizational behavior researchers here at Sloan, all fascinated by this transformation of US healthcare toward new delivery models. And so a big change there is instead of paying for each episode when someone goes to the hospital, acute problem arises, we've been paying for problems. And so as economists, we worry that if you keep paying for problems, then there's not much of an incentive to prevent the problems, that you might actually find more problems, just go looking for problems. These are basic economic incentives. If we start paying for value or help keeping people well, then there will be an incentive to devote the time and effort into new care models that will actually try to keep people well. We all think prevention is generally more efficient than cures. And so if we could, that would be a huge disruption, if you will, of US healthcare, is moving from paying for problems all the time toward paying for keeping a population well. And so what fascinates me as an economist is that one of the main drivers of why people are unwell are not how much healthcare they receive. That's basically a small slice of how well we are. That's trying to mop up a problem after it's already been caused. Social determinants of health. So these are how basically everything outside the clinic that affects your health, your behaviors, your diet, your income. These things have a huge predictive power in terms of mortality and other health outcomes far beyond what we see in healthcare. So healthcare is still important. We're willing to pay a lot for it. If we get sick, we want to get well, but we could see a huge change in the way we provide healthcare in a way that would actually try to keep people well by addressing these social determinants of health. And that's the focus of today's talk. This is what the whole person healthcare title came from. So these present new management issues, right? New financing, we worry about economics and finance. New delivery models, well, we need to develop those models with our operations research folks can do that, or our organizational behavior folks can think about how do organizations change. And so here at MIT, these new management issues comes right into where MIT can provide a nice sort of unique voice by looking at across all these management lenses of economics and finance, operations and organizational behavior that can provide insights into how we can make this transition in a way that that improves everyone's well-being. All right, so here's an example of, I'm not seeing my full screen, so I'm not sure if you are, but I have this map. It's a subway map of New York City. For those of you from New York, you recognize it. And if you go from the Upper East Side, that goes about from 85th Street, 86th Street, and you go up to 149th Street, life expectancy drops by about 10 years. So just the 6 months is lost for every minute that you ride in the train, or about 3.2 years are lost for every mile. It's just amazing how different our life expectancies are based on our census tract or our zip code that we live in. And this gets to how much is it of the genetic code that matters versus your zip code is sort of a catchy way to put it, that what you can really predict how people are going to fare in terms of their health based on their income, socioeconomic status. It's just a major determinant of health. So here, if you want to go closer to home in Boston, you look at the percent of adults with diabetes by T-stops. if you get off on the blue line in Maverick, 11% will have diabetes. If you get off in Fenway, despite all the Fenway Franks and beer sold in the area, you get 2% of adults with diabetes. So just dramatic differences in disease prevalence across the city. And so you might think that that's not due to different quality of institutions in the area, because we have great institutions. It's about the social determinants of health. And so they come in lots of different buckets. So transportation, can people get to their appointments easily? Well, in rural areas, that might be difficult. In some cities, that might be difficult. So we've been increasingly seeing services coming up. How do we get people to their appointments? Maybe Uber Health, for example. Education, do people understand how to adhere to their regimens? Some people have complex diseases. They'll have 5 different diseases. They're on 10 different medications. It'd be difficult for us to try to figure out how to manage your day if you had to manage all those diseases. And so we can see where education can come in there. It also comes into income. Higher educated people, of course, make more money, and that there's a very strong wealth health gradient. The richer people get, the healthier that they get. Isolation is another one where you think about depression and loneliness comes from not seeing people. Housing stability is one of the areas that's gotten a lot of evidence. So there are about 6 or 7 really rigorous studies showing that if you get homeless populations into sheltered into housing, that their health improves. And actually their involvement with criminal justice goes down as well. So that it seems like it's a net gain to society to get, to target getting people housed who aren't housed. It's called housing first, because the idea is you can't treat someone's diseases and get them taking their medications and so on if the person's doesn't have a home. And then the last one is hunger, which is important. I'll talk mostly about that. So in terms of social determinants of health, this is a very exciting time to think about studying health economics and healthcare in general. So CMS, the Centers for Medicare and Medicaid Services, announced in November last year the Medicare Advantage. These are private plans that help administer health Medicare. They can start paying for social determinants of health interventions in 2020. So most of the insurers are thinking about, Aetna, United Healthcare, they're thinking about, well, where should they invest money in order to keep people well? And there's a lot of uncertainty out there. There's some good logic that it could work, but there's not much evidence yet. So current examples of Medicaid would be housing the like I've already said, there's some good evidence that housing first works. And then food as medicine is a very popular topic. So instead of prescribing insulin for diabetics, maybe we should be prescribing healthier diets. And that's the topic that I want to go into in most detail. All right, so that's just to pause for a moment because I've been talking for a while. That's the end of the background, that the US healthcare system is moving toward paying for quantity of care, toward paying for value in healthcare. And what that means is that providers are going to be held responsible for how well their populations are. And when the financial incentives shift, that will provide the incentives for devoting the time and effort to innovate on new models that will be trying to address population health. We don't have a great history of this, and partly I think it's because we haven't had enough resources devoted into developing those interventions. And for those of you, starting new businesses and thinking about how to disrupt healthcare, this is a place where there'll be a lot of interest in how do we change the way we provide care with telemedicine, with remote monitoring of patients, with different digital health tools that can help remind patients to adhere and to affect their behaviors. There'll be a lot of interest from payers in terms of adopting these things, as well as providers who are taking on more risk. All right, so now I just wanted to give some descriptions of the work that I'm doing because I'm most excited about it. Also, I'm an expert on what I'm doing in particular. So when we have question and answer, I'm very comfortable answering all these questions. Of course, I could talk about some of the other work at Sloan as well. So the first time I got into running randomized controlled trials was this project called hotspotting. So about 15 years ago, this physician in Camden, New Jersey, which is a high poverty city outside of Philadelphia, he came up with this idea of hotspotting. And his idea was he mapped the city of Camden and found where the healthcare spending arose, which census tracts was responsible for the most spending. And you could put up these heat maps, and you could just see, partly because of that social determinants of health that I talked about before with the subway map, you can see that on any city, especially You can certainly see it in Camden. In fact, he found that 1% of patients in Camden, 1%, accounted for 30% of all healthcare spending. So this idea morphed into not only treating the census tracts that have the most spending, but the patients who drive the most spending. So you identify who are the patients who are driving most of the spending. And then if you could re-engineer how you treat those patients, if you could do it more efficiently, well, you could imagine that there would be a lot of savings. And the US as a whole has similar numbers. 1%, 30% is common. You often hear that 5% of people in the US account for half of all spending. Okay, so that's true nationwide. And so if you were able to address those that 1%, you know, we spend about $3 trillion in healthcare. So, you know, we're talking about $1 trillion almost of spending if you could address how we spend on that top 1%. So what was the idea of treating this top 1%? How are we going to go about doing it? Well, this Dr. Jeff Brenner won a MacArthur Genius Award and was written up in the New Yorker, and is really an amazing guy, huge thought leader in this area. His idea was to lavish, if you will, care management on these patients, where you'd have many home visits over about a 6-month period. You'd be sending people in a team of about 10 people who are monitoring this patient, sending some nurses, community health workers to their home, and then addressing not only their clinical needs, but their social needs as well. So getting people signed up for food stamps, getting them signed up for other government programs, getting them transportation to their healthcare providers, teaching them how to use healthcare in a new way, not going to the emergency room all the time, for example, but going to the primary care physician, trying to head off some of their problems. And if you look at, they were really focusing on these complex cases. And like I said before, if you had these complex conditions, you would need a team to help you navigate the US healthcare system. It's just very complicated. And so there's this real logic that this program could work. Now, this program has been extremely influential. It's been started up in about, and across the country. There have been Centers for Medicare, Medicaid Services funded about 5 other sites to try the idea. It's been tried other places with other support as well. But there really isn't much rigorous evidence on whether this particular program works. There is some rigorous evidence on related parts of the program, but not on this package itself that's so influential. So Jeff Brenner wanted to know if this program actually worked, and so he teamed up with MIT, Amy Finkelstein in the economics department, and I teamed up with him to run a randomized controlled trial. So they went through their normal eligibility criteria. They found out that somebody was eligible for the program, and then we randomized whether they would get the program now or they had to wait a year to get into the program. And the reason why that was ethically reasonable are 2 reasons. One is there were capacity constraints. So they couldn't treat everybody that they saw was eligible for their program anyway. They had 2 teams of about 10 people. They couldn't treat everybody with the caseloads that they thought were necessary in order to provide quality care. The second reason is what we call clinical equipoise. We don't know whether the program really works. And so before spending billions of dollars on a program like this across the country, we have to know whether it works or not. And so that's another justification for why we might randomize. I think the capacity constraint one is particularly compelling in this example. So we'll it takes about a year to 18 months to recruit enough patients into the sample in order to get statistical precision, and then we're tracking their outcomes for about a year after that. So this type of project is not a quick one-off. You don't get this done in a couple months. It takes a couple of years to run this type of project, and we'll be having results from this study coming out in the fall. So look out for those. I'm excited to talk more about it then. Another project that we have is that I'm working on is with United Healthcare, which we're paying people to get their wellness visits. So instead of having a co-payment to get a wellness visit, we're actually going to pay them to get a wellness visit. And just to bring it back as well, why do economists study this? So this is clear, right? That we're trying to use financial incentives for people to go do healthier behaviors. The second reason that economists do it, instead of, say, a public health person that also does similar things, how do we do things a little bit differently? We try to unpack the underlying economics of the healthy behaviors. And in this case, we're interested in the complementarities within families. So if you incentivize a family, let's say the kids have to get their wellness visits. Let's say we incentivize the kids to get them. So the parents, if they get your kids to wellness visits, you're going to get paid $100. Does that increase or decrease the likelihood that the mother gets her wellness visit, right? She might be going to the medical area and get her visits, or these other visits may actually compete with her time. And so she might be less likely to get the visits. And by understanding those within family complementarities, we could think about how to optimize the right subsidy. Maybe it's really getting the kids in that's easier to do with money, and that also brings along the benefit of getting the parents. Well, then we would know that we should be doing these type of incentive programs for kids that would have these other spillover effects. So you can see where we use typical economics concepts like complements and substitutes in order to inform how we analyze the results of these types of studies. Okay, in the last 10 minutes or so, I would like to talk about my favorite project, because it just got started last week in terms of recruiting patients, which is called the Fresh Food Pharmacy Program at Geisinger Health. Many of you have probably heard of Geisinger. Geisinger is a payer provider in northeastern and central Pennsylvania. By payer provider, I mean that they are an insurance company that also is a health system. They own the hospitals, they own clinics, they pay physicians, largely salaried are their physicians. So they're a health system that's also an insurance company. And so if they can keep their patients well, that will actually lead to higher profits for the organization as a whole. So now we're really, their incentives are really aligned to get people that get their patients well. In other systems, it's not that systems don't want to get their patients well, but if their patients get sick, they actually get paid more. And so where do you, we see this all the time, where do people devote their energy toward spending a lot of time to innovate? It's places where you could see a return on investment. That's just the fact that it's not a positive, it's not a normative idea, it's a positive idea, meaning just a fact from economics that when things are going to drive increased profits or increased well-being for people, that's where they're devoting their attention. And we see that all the time. So Geisinger's held as really a nationwide leader in innovating on how to keep people well. And one of their flagship programs is called the Fresh Food Pharmacy. And so you can see a picture here of the pharmacy. And so what do they do with the pharmacy? Here, it's lots of people smiling. So first of all, it's a very friendly environment. They've recruited nurses and health coaches who are screened based on basically customer service type metrics. How friendly are they? They want to have a very feel-good environment in this clinic that they've set up that's also distributing food. So here's what it is. They prescribe healthy meals to food insecure diabetics or patients with diabetes. So these are patients that are lower socioeconomic status. They report that they have trouble meeting their food needs, and they're also diabetic. So this food insecurity goes hand in hand with diabetes, because it's hard to eat healthy when you don't have much money to pay for food. It's just cheaper to feel full on less healthy foods. And so that just combines to lead to sort of a vicious cycle. So they're prescribing healthy meals to these patients. Now you might say, every time you go to the doctor, they say to you, you should eat healthy and you should exercise more. That's kind of like a prescription. But what's different here is that patients fill their prescription each week at a fresh food pharmacy clinic. It's a brick and mortar clinic where patients go, and they're referred there, and they can pick up about 10 plus meals per week. So most of their food for the week, not only for themselves, but for their entire family. The reason why it's not every meal, 7 meals a day, 7 days a week, is because they recognize that patients will want to buy some food on their own, that they're not going to only eat the food that comes from the fresh food pharmacy. What comes with this prescription as well, not only do they come back for the food, but they get education about how to use the food. So they have dietitian consultations and nurses helping them how to use the food. They have group cooking classes that are a lot of fun. The point is to have these as a feel-good environment, like I said. They also get recipes each week of how to use the new foods and menus of how, and there's a big emphasis on their cooking classes on portion size, which is vital for diabetics. And then not only do they get education about nutrition, but they get education about diabetes itself. So how do they screen for complications and make sure the patients know that they should be getting eye exams, foot exams, they should be monitoring their blood sugar. They get patients vaccinations. They get a self-management education, diabetes self-management education course that they go through. Now, yeah, so there are a couple of reasons why this might improve health, and this kind of gets back to how an economist would look at this type of program as opposed to, say, an endocrinologist. So we're thinking about the healthy behaviors and how do we use an economics framework that you learned here at Sloan to think about this type of topic. So the first thing is it lowers the cost of eating healthy meals. We're dramatically lowering the cost of eating healthier. The relative price of healthy meals to, say, going to a fast food goes to zero. It's also an experience good to have, say, fish or new types of vegetables. When I've been to a few site visits there, and it's a very inspiring place. And what you learn is that it's risky. These patients find it risky to purchase, say, fish or these new vegetables in a supermarket because they're not sure their family will like it. But here we're changing that risk. There's no risk to trying these new foods. And maybe they'll find that they like some of the vegetables, or now cooking fish in a right way where it doesn't get all dry, then maybe they'll like fish and it can change habits. They also learn how to provide the healthy meals, so there's just this direct education piece that could affect how you behave. That's changing the cost of eating healthy meals because now you know how to prepare them. The second thing is that, of course, it provides an income effect. We're providing a lot of healthy food to low socioeconomic status individuals. That's going to make them feel better off in terms of they're just richer than they otherwise would have been. That lowers stress and so on. The third thing I find really interesting is it lowers the stigma associated with addressing your food insecurity. Right now, you might be referred to a community-based organization called a food bank. But a lot of patients don't want to go to a food bank. They feel like it's too much of a charity, that there's a stigma attached to going to it. You know, hopefully we could educate people that there shouldn't be a stigma to that. You should address your food insecurity, but that's just a fact. Whereas if you refer people to a clinic where we're going to teach you about your diabetes, it just leapfrogs this barrier to getting people to behave healthier. Everybody takes up the fresh food pharmacy when they're offered it. It's a feel-good environment being dictated to by their physicians, and so they just feel like this is part of their health care. And the last thing is that it improves their self-efficacy or your self-esteem. Patients there feel like they have more control, and that can lead to improved adherence for lots of kinds of healthy behaviors. So our study will try to test all these ideas of whether their fresh food pharmacy is working or not. Now, in terms of background, there have been some observational studies finding huge improvements of people who get these food as medicine interventions. You know, 30 to 50% lower utilization after a year. And in fact, Geisinger themselves have published policy pieces. These aren't rigorous studies, but they're policy pieces finding 80% drop in healthcare costs over 18 months. These are just gigantic numbers. It's hard to put your head around them. And in fact, a lot of payers and providers around the country find that this looks promising, but they don't trust these numbers of 80% drops in costs. It's just sort of too good to be believed, and they don't have that rigorous approach to try to estimate these effects. So they teamed up with MIT in order to do that. Even though it's been heralded in the national press, they've gotten a lot of good publicity about this program. They actually want to know if their program works. So remember, they're this payer provider who actually benefit financially if they keep their patients well. So they really want to know what kind of return they're getting on this kind of investment. So they're expanding to two new cities. In fact, they just expanded to Scranton, Pennsylvania a couple of weeks ago. And then they're expanding to Lewistown, Pennsylvania in a few weeks from now. And what's beautiful about our study in terms of the credibility of it is that we're randomizing among the new patients. They can't treat everyone on day one. So we're randomizing who gets to start now versus who has to wait 6 to 9 months later in order to get onto the program. And then we're going to be able to look at a host of outcomes like their blood sugar, like their utilization of healthcare services, to see if this program actually does improve health, or whether people are getting all this healthy food, they're eating some of it, but then they're also eating a lot of other food that's not so healthy, and in fact, we're just adding calories to people instead of reducing them. We have a strong hypothesis that we think it will lead to healthier eating and improve health, but this study will be the first large-scale randomized trial of a healthcare delivery initiative like this run through a healthcare clinic. And I think that's so important because of the diabetes education comes from there, the stigma reducing factor comes from there, and I'm really excited to see what we find. So going forward, there's a lot of interest from other Medicaid accountable care organizations to experiment on this type of approach. We're curious, like, how long should the program last in order to address habit formation? This is how preferences get determined from our economics background, as you remember. How much food should we give? That affects price and income effects that we talked about before. And then how should it be provided? Should it be in the clinic like it does at Geisinger, or there are other programs that deliver food, healthy food, to people's homes? And I'm excited to study all these types of parameters as we go forward. So just to finish there, and before we get to some closing comments and then some Q&A, we are in the cusp of healthcare, our healthcare systems addressing social determinants of health. This is the time as we're rolling out new approaches, to study them in a very rigorous way. We could roll them out in systematic ways in order to really test whether they work, like we're doing at Geisinger. So now's the time for discoveries, and stay tuned. I'm excited to tell you more about what we find in the future and the collaboration. So a lot of what this project started at Geisinger, just I'll finish on this note, because Alistair Erskine was the Chief Information Officer at Geisinger, and I met with Alistair when he was here on campus, and he put me in touch with them about one of their more exciting projects that they were embarking on, which was the expansion of their fresh food pharmacy program. So this research project, which is my favorite project at the moment, was started with discussions with Sloan. So I'm very excited to continue those types of discussions and think about where collaboration opportunities can come in.
Great, thank you, Joe. As a reminder to our participants, you can type in your questions in the Q&A panel in the Zoom interface. And while you're doing that, I'll take a moment to tell you about some upcoming events. Coming up in June, during Reunion Weekend 2019, June 6th, 7th, and 8th, whether you're celebrating a reunion or not, plan to tune in online. We are offering 3 sessions live from Reunion Weekend, including Executive Education at MIT Sloan, an update from Peter Hurst, Senior Associate Dean of Executive Education. We'll be offering Alumni Tim Talks, which are short TED-style talks from alumni, peers, and classmates, so tune in for that. And we'll also have a presentation from Renee Richardson-Goslin, who's a senior lecturer and research scientist in the marketing group here on campus at Sloan. So whether you can make it back for reunion or not, whether you're in a reunion year or not, please tune in. We'd love to have you join us. So you can register for these and more sessions on the web address on your screen. You can also find links to our previously recorded sessions on our YouTube channel. And so now for our Q&A. To get us started, Joe, thank you again for sharing your work. We really appreciate that. Really great, exciting initiatives. So one question that has come in from an alum to kick us off, maybe if you could comment a little bit on how can individual healthcare providers best drive change? I think it may seem as an insurmountable hurdle, but what can individual healthcare providers do to get started with this type of approach?
Right, so there's a lot of work to be done as these healthcare payment models are shifting. That provides senior management at healthcare providers to understand that it could be valuable to invest in the time and effort and the labor force to try to come up with new ideas of how to improve the health of their patients. And that means new ways of delivering care. It means addressing new things like hiring social workers and health coaches to address social determinants and other topics. And what we need is a voice from providers, physicians, nurses. We want, as we know from organizational behavior, you can't have organizations change unless you have buy-in from the providers. So, if you're convinced that there's a new way to deliver care to get your patients healthier, and before you didn't have the time, the resources to carve out time to work on that, this is the time to go to senior leaders and say, look, we're being asked to take on more and more risk. We need to start innovating on how to deliver care better. And so let's carve out some time in order to do so. You're going to get more and more receptive administrators will become more and more receptive to those types of requests to innovate on how to deliver care. So one is idea generation. Providers have ideas of how they think the system could be improved. The second one then is actually putting effort into those ideas by carving out time and getting your administrators to subsidize carving out that time to learn about those ideas. And then last, I think in order to get payers and providers to adopt new ideas and to amplify the impact of any discoveries that you make, I find, and I'm a researcher, but I find it's critical that you have rigorous evidence evaluation for what you try, whether it works or not. So even on whether you're going to publish a study or not, organizations need to collect the data, which is increasingly easy to do, to try new innovations and then track their outcomes, ideally with a comparison group, such that it's credible. When you find differences in the outcomes, you can attribute it to that change in intervention. We need to have the intellectual horsepower that comes from Sloan is that, this idea should be right in your wheelhouse, that we need to collect the data and we need to rigorously test what works and what doesn't. Otherwise, we might be chasing our tail and we just won't be able to observe it. So whether that's sort of private quality initiative type research within organizations, but ideally more broadly collaborating with MIT if you want, but getting at what you learn out there of what works by testing what works in a credible way, I feel like that's a critical component that, of course, I think that because I'm a researcher, but I think that it should ring true.
Great, thank you, Joe. And I'm thinking back to one of your slides towards the very beginning of the presentation where you showed the increase in healthcare costs in the United States compared to other countries. So one question that came in from an alum is, have any of your research looked at administrative expenses on healthcare prices as compared to the cost of the care itself?
Right, so oftentimes when that graph had cross-country comparisons on it. So we had the United States at the top with that growing line, and then you had a lot of other countries. It was kind of hard to see in the graph, they were grayed out, but then they had the average for the other industrialized countries growing, but not as fast. And oftentimes people will bring up, well, the administrative costs are lower in a single payer system, for example. So you wouldn't have as much paperwork or say competing advertising across private firms and so on. I mean, that's a general issue with private markets, that we have multiple companies with their own fixed costs. And we typically don't think that one monopoly run by the government is going to be the solution in most things. Whereas healthcare, we do, and one reason why people make that argument is because if people get sick, we have a moral obligation to treat them. Whereas if people want a Ferrari, we don't have a moral obligation to provide them a Ferrari. So if we're going to have to treat people when they get sick, then we have to come up with a way to share the cost of providing healthcare for everyone. In the US, we do that in a number of ways. We have a private system that does have higher administrative costs in terms of that extra paperwork and so on, and maybe we could have policies that try to streamline some of that. I do want to caution a bit though so Medicare for all is a very popular topic. I find it to be fascinating discussion. But one of the claims made is that Medicare has lower administrative costs. And there I get a little nervous because Medicare is, as I see it, is a very good check writing organization. They do a lot of research and so on, but they don't have the political will based on their backers and the legislature. The legislature just doesn't have the political will to say no to things. So one reason why providers like being paid by Medicare is because there are fewer hurdles to getting paid. Private insurance companies have higher administrative costs because they're putting in more effort into trying to figure out whether they should pay for things, and they do create hurdles to pay for things that they feel are low value. So then there's just a disagreement among the payer and the provider, and it could become an adversarial relationship, whereas Medicare doesn't have that same. If we went to a Medicare for all and we switched from private payers to all public payers, if we continue to not ration care at all and it just keeps growing over relative to, if the Medicare doesn't ration care relative to what the private payers do in terms of quantity of care, then we could continue to have this growing amount of healthcare spending and someday we're going to have to start rationing care. And the question is whether Medicare is the right place to do that.
Great, thank you. So this next question is maybe a little bit on process. So I'm quoting from the Q&A box here, but fully recognizing the value of rigorously testing an approach, but is there still a path forward for ideas that don't necessarily warrant a full randomized study approach? Yeah,
so randomized trials don't fit every situation. There are lots of times where it might be impractical to do an RCT, or we know something just works, and so you're not going to test it. The classic example is that there's no RCTs, randomized controlled trials, for parachutes, right? You're not going to bring people up in an airplane and half of them are going to give a parachute and half not and kick them all out of the plane. And we know if something we know it works, then there's really no reason to test it. Take food as medicine. It just has a lot of logic that it could work, but you could easily imagine some people I talk to think it's not going to work because it's very difficult to change people's diets. I think going in thinking it will work because it's such a big hammer. We're just giving a lot of healthy foods that I think it will have to substitute. I'm using my economics background now that I think it will that relative price of eating healthier is just going to be so much better that it should have an effect based on our current estimates of how people should respond to that. But we really have to see whether it works in the field. So there are plenty of times where we just go ahead and do things that we expect work. without the rigorous evidence. If it's any reason why you think it might not work, you need that rigorous evidence, I feel, in order to get other payers and providers to adopt. So if you want to scale something across the country, you're going to want to have evidence that shows that either it improves health or lowers costs or both.
Great, thank you. And Joe, wondering if you can comment on, what are the opportunities that you see for entrepreneurs to do well in this space, and maybe starting businesses that are focusing on the social determinants of health?
Right. So here at MIT, right, we start. There's a lot of companies get started. It's a vibrant place, and a lot of you out there listening is right in the crux of this. So there's just so much to talk about there. But digital health tools are where there's going to be a shakeout at some point in which ones take off and which ones don't. But we're not there yet in terms of how do we best measure how well patients are doing in terms of their health. How do we bring in social determinants data and health data together in ways that can then predict who will get sick tomorrow, but also what type of interventions work, sort of personalized medicine. Tons of interest in this area, tons of startups trying to figure out how best to combine data to give advice to providers and patients. I think disrupting on the patient side is interesting. So if there's a lot of demand for people trying to figure out how they can be the healthier themselves. And so providing more tools that do that will be important. But also people who are on the margin there where they're not particularly health conscious, but if you can make it easier for them to, say, adhere to their drugs, maybe with some peer pressure from their family, knowing if they're adhering to their drugs and things like that, but financial incentives, social incentives, that would be bringing in a lot of social science and management tools in order to think about how you could change the way people are behaving. I feel like there's a lot of scope there, because of entrepreneurs think about the customer experience and how customers behave. We could use that type of focus in this environment where we think about healthy behaviors. How do we get patients to behave healthier, and then ultimately show that return on investment?
Thank you, Joe. So another question that came in relates to workplace wellness programs. The comment states that studies have found that wellness programs at organizations aren't working at either saving the employers money on healthcare costs or in keeping employees healthy. So curious for your thoughts on that, and what can we learn to make prevention and health programs more sustainable in the long run?
Okay, that's a fantastic question. I kind of give economists a pat on the back here for bringing some more rigor to this debate, where you've had two large-scale randomized controlled trials recently over the last year, tens of thousands of people finding that workplace wellness programs don't save money for employers over the first year. Some evidence that if you incentivize healthy behaviors, you get people to behave healthier, but you don't save money. Now, you might think the reason why I emphasize on the first year is because it may take a while to have people eating healthier or behaving healthier for that to show up in terms of improved health outcomes at lower utilization. You might not expect to find effects at 1 year. So I think the headlines in the newspaper are workplace wellness programs don't work. I would say they don't work within a year, at least according to the best evidence we have in terms of saving money. We do find that people who take up workplace wellness programs, we learn about, we learned at Sloan about adverse selection, right, from your economics days. And you get this opposite of that, where you have this advantageous selection. The people who sign up for wellness programs, they already want to be well, and they already are going to the gym. So they take their financial incentives or the perks that go along with it sort of for free. And what you want to do is be shifting people. So how can we make it work better? One is to measure these outcomes over longer time periods to see if it actually does save money. And I think it's important in this context that the previous work that found that the people who sign up for these programs have lower healthcare costs over 1 year, they were making these claims that they had these huge returns over 1 year. And it's because of this advantageous selection that you could easily get the people who sign up for wellness programs are naturally on a better trajectory in terms of their healthcare spending than the people who don't. And so it's really hard to compare those two groups because you don't have this shift, this exogenous or like as good as random assignment. Whereas these randomized controlled trials do give you that apples to apples comparison of people. Some people are allowed to use these programs. Some people basically are held out of those programs randomly. And then you find that there's no difference in their healthcare spending for the two groups over the next year. So I'd say, one, it pumps the brakes a bit on that these programs are just, huge returns on investment in the first year. So I hope that it actually encourages more thinking about how we can change behaviors even more instead of just saying they're already working great. These types of research will hopefully motivate more effort into how do you get people behaving even healthier. And we need to track these outcomes and run longer term trials to see if you see some, at least some endpoints like blood sugar, like blood pressure, things that are intermediate outcomes that you could observe over a year or 2 or 2 years in order to see if these programs have an effect.
Great, thank you. And so one question that we're hoping to get a comment from you on is, you're doing a lot of great work and a lot of lessons learned and sharing of those, but how can maybe some of those lessons be applied outside of the United States? Or do you see any easy applications for the developing world?
Sure, so these non-communicable diseases like diabetes, very common among other developed countries, for example, and then increasingly common in developing countries. So you can see that a lot of eyes from other healthcare programs that also care about population health management, but they're excited as well to see 1,000 flowers bloom here in the U.S. As the financial incentives change here, we'll see a lot of experimentation on what works and what doesn't. The goal is for those lessons then to be broadcast, and they will be adopted by other healthcare systems if they are lowering costs and improving health. We're going to expand the evidence base based on all of this experimentation that happens, driven by this new financial incentive that we're creating and putting risk onto the providers. Other programs or government hospitals, for example, they have a different set of financial incentives. One of the results from economics looks at do for-profit hospitals behave differently than non-profit hospitals versus government hospitals? And a lot of things that there's a change in costs or a change in the price and so on. You see that the response of nonprofits and for-profit hospitals are often very similar to each other. But government hospitals behave differently. They just look like they're not maximizing the same objective function. They're just doing something different. And so you might think in other countries that might apply there as well, that they're doing something different, but they still, we're hoping would be adopting new innovations of keeping populations well, in part through their own social service agencies and through their departments of health. JPAL, like I said, we have about 150 randomized controlled trials around the world on health topics, and the majority of those are in developing countries. And so we are putting that intellectual rigor, we're shining using that tool across the world, not just in the US.
Great, thank you, Joe. And maybe to close this out, we're nearing the top of the hour, but for the last question, you mentioned some upcoming studies that will be published this fall, and that you're very excited about that. Just maybe if you could give us a few words, like, again, recapping, what are you most excited about for this summer and for your ongoing work, and maybe even beyond the fall?
Yeah, so I'm still doing these randomized controlled trials, whether that's planning them or analyzing the ones that have come out and then publishing on them. So in the fall, like I said, we'll be doing the hotspotting RCT results will be coming out. So we'll be able to talk about whether or not that flagship program is saving money or not, is improving the health of patients or not. And then the fresh food pharmacy one will be monitoring it. And the United Healthcare program will also be, over the summer, we'll be working on writing up the results for that. If we pay people for their wellness visits, can we get them to do them? In addition to my RCT work, which I'm also planning other ones, I do a lot with big data sets, as you might imagine, here at Sloan. And what I'm most excited there is bringing more causality into these big data tools. I teach a course in econometrics here at Sloan, and the contrast between machine learning tools that are very good at finding correlations. So we can predict who will become sick next year based on their data. But what we want to know is if you can predict who's going to be sick, if we intervene, if we do something about it, if we do something, does it actually improve health? That's a causal statement. And the machine learning tools are very good at getting these correlations, but they're less good at trying to tease out causality, what causes what. And I'm working now on trying to bring my expertise in natural experiments and finding as good as random variation in historical data, and layering over that these machine learning tools in a way that can try to start to get to causality using these exciting new tools. So I'm really excited about that part as well.
Great. Well, thank you, Joe. And it's no question that you and your work, you're building a better world through health. So we appreciate your time and sharing your research and sharing with the alumni community today. So thank you for joining us. And
My pleasure.
I'd also like to thank all of our viewers for joining us. To keep this conversation going on social media, you can use the hashtag #SloanChat. Following this event, you will receive a survey via email, and we will be including a slide deck for our folks there. So please fill out that survey and let us know your feedback on this session, as well as our ongoing lineup of webinars. As always, you can reach out to us at Sloan Alumni Online at mit.edu. Thanks for joining us today, and thanks again, Professor Doyle.
Thank you.